There will be some overlap with what Arnaud presented earlier, but the developments are not so many, and I think many things may be seen with from another view. These are my disclosures. So Arnaud already explained very nicely the pathway to diagnosis, but after diagnosis, the next step is to risk stratify the patient, and we have to make, at least in my view, a decision about the eligibility of the patient for a clinical trial in order to receive a new treatment that may not be available yet, that could further improve the outcome of the patient, and of course then to decide the appropriate therapy, and the standard of care were already shown by Arnaud. We have to remember, first of all, what are the goals of treatment for our patients with AL amyloidosis. First of all, we have to remember that we have two levels of response. The first level of response is what we call the hematologic response, the reduction of the free light chains, of the toxic immunoglobulin that causes the disease. And we require to have a deep hematologic response in order to have a meaningful organ response and improvement in the survival, in the symptoms, and the quality of life. So the first question is, how deep should the response be? And Arnaud already said that it should be at least VGPR, even better CR, even better MRD negative by MS or by flow cytometry. And the second question is, how fast do we need to have this response? Can we wait? How long can we wait? We have to remember that the criteria for the hematologic response in AL amyloidosis are different from the criteria that we use in myeloma. We rely a lot on the free light chain measurement. We have to remember what Arnaud said, that there are different methods to measure the free light chains, and we have to be careful in the evaluation. And the absolute level of the residual free light chain is very important, because these patients that achieve a very deep hematologic response have the best outcome. And then the second level of response is organ response. And we have to remember that we need a hematologic response in order to have an organ response. This is delayed. The organ responses, usually they lag behind hematologic responses by 3, 6, 9 months, 1 year, 2 years, or 3 years. So one has to be very cautious when evaluating the organ responses. But also we have to remember that in some cases, in some patients, it's maybe too late. The disease has progressed so much, the organ has a damage that is beyond repair, and the organs may fail, and we see that in many patients with renal involvement or even with cardiac involvement, despite the achievement of a very good hematologic response. So ideally, what we want is a CR, even better undetectable MRD. I don't know which method is the best to evaluate the residual clone or the residual light chains. We have to be very fast. Well, the fast definition of what is fast, we can discuss. And also we have to remember that most of the patients who present with stage 2 or stage 3 AL amyloidosis are frail, and we have to be very cautious regarding the toxicity of the drugs. For example, yesterday there was a case with a very severe autonomic dysfunction, so it's not easy to give bortezomib in such a patient. So we have to be very careful with all the toxicities caused by the treatment. So this is the approach that ISA is proposing. So patients who fail to achieve a VGPR after 3 months should be considered for perhaps a change in therapy, and I think Arnaud also emphasized this. However, we have data showing that a delay to achieve a VGPR just by 2 months. So if you take patients who have achieved a VGPR or better within the first month versus they achieved at 3 months, and this is a landmark analysis, they still have a difference in the overall survival. So this delay of just 2 months to achieve a very good hematologic response may have detrimental effects in the patients. And also, less than a quarter of the patients who have failed to achieve a VGPR or better within the first month, they will achieve this response if they continue the same therapy by 3 months. And of course, this is the retrospective data from our center, but the data from Andromeda show exactly the same thing. So if you see the difference here and the numbers, you will see that actually after 2 additional months of the same therapy that failed to achieve a VGPR within the first month, only few patients, very few patients, less than 15%, they improve their response. So that is why I think that with the new treatments that are coming today, and some of them were presented by Arnaud, like venetoclax for some patients, we have to be more aggressive, especially for high-risk patients, when we want to achieve a deep hematologic response, and we should try to achieve this response as fast as possible, probably within the first 2 or 4 weeks, as Arnaud showed. In order to achieve this, we have this the regimens that are shown here and have already been presented: bortezomib with alkylating agents, or bortezomib with alkylating agents and daratumumab. This is the standard of care now. However, we have to remember that for patients who were enrolled in randomized clinical trials, like the EMN02 and the Andromeda study, patients with stage 3B were excluded, so we have to be cautious when we interpret these results in patients with very high-risk disease. Arnaud already showed the very good results from the Andromeda, so this is today the standard of care, rapidly acting, very high rates of hematologic responses and of organ responses. However, we have to remember that for patients with stage 3B disease, things are not the same. Achieving a rapid hematologic response, it is very important, but still we are losing patients. And what we must reduce in these patients is early mortality. So in the EMN22 study that Arnaud already said a few things, the primary endpoint was the overall survival at 6 months. We chose this endpoint because indeed these patients are at very high risk for early death, about 50 to 60% within the first 6 months. And as you can see here, there was a reduction in the overall mortality within the first 6 months to 35% from about 50 to 60%. This is very important. And also the secondary endpoint of hematologic responses with daratumumab as a monotherapy was very high. So daratumumab is a very well-tolerated drug. It can induce very rapid hematologic responses, probably is not increasing early mortality. But still, we need to improve. How can we improve? What about adding another agent to daratumumab? But which agent? Should be bortezomib, should be venetoclax, should be another new drug? Should we just put another drug, each week, add another drug until we find the regimen that our patients can tolerate? What is very important, however, is that if you achieve a good hematologic response very rapidly, even in these patients, you can really change the outcome of this disease. And also, there is a high probability that these patients may achieve, with monotherapy, a cardiac response. So as you can see, 50% of the patients, they achieve the cardiac response, and also a very significant proportion of the patients, about 1/3, they achieve what we call today a deep cardiac response, very good partial cardiac response, or complete cardiac response. So even though these were patients with very advanced cardiac disease, it is, we can, in many of them, achieve a very good cardiac response, which means good survival and good quality of life. However, all the studies that have evaluated daratumumab-based therapies in patients with stage 3B, they show the same thing. About 35% of early mortality with the first 6 to 12 months. So can we improve that? Can we expect that the new monoclonal antibodies targeting amyloid can change the outcome of these patients? We will have to see the results of the ongoing studies. Now, there are, of course, other daratumumab-based regimens that were presented in ISA about a month ago. So this is a study from the UK, from Ashuve Chalekar and his colleagues. So as you can see, they evaluated daratumumab with VTD, which is the approved regimen for patients with myeloma. Now it will be also dara-VRD. And as you can see, the CR rates and the VGPR rates are very high, but are probably very similar to the rates that we achieve with dara-VCD. So I don't know if adding thalidomide really improves the outcome of patients with AL amyloidosis. We already heard about T1114, and Stefan Schönland yesterday showed very elegantly the importance of T1114. About 50% of our patients have T1114. We know what with daratumumab we can probably overcome the adverse effect of T1114 in those treated with VCD. However, the elephant here is venetoclax. Venetoclax is very active in these patients. We all use venetoclax. I know we all use venetoclax one way or the other. If we overcome, the restrictions of the funding, depending on the country. The problem is that we all know that it's a very effective drug, but we have no prospective trial so far. So we use a drug based only on retrospective data, and there were some updates in the ISA from small studies again showing very high rates of responses in patients with T1114. What about transplantation? So transplantation is a good treatment. I know that Arnaud does not agree, but for some patients, it's a very good treatment, and the responses can be very, very long-lasting. And some patients may never need any other therapy for decades if they achieve a CR after autologous transplantation. Well, of course, when you have very effective therapies like dara-VCD, should you use transplantation up front? Should we keep it for patients who fail to achieve a CR or a VGPR? So it seems that if you defer transplantation, probably you don't lose something. The patients will still have a good prognosis. Of course, these are patients who are eligible for transplantation, so they are, let's say, in a good prognostic group. But I think that transplantation is still a reasonable option for some very carefully selected patients. And these are the ISA guidelines written by Vaishali Sanchoravala. Of course, there are many issues here, like the dose of the use of induction, the dose of melphalan. It's very important to use the full dose unless there is a renal dysfunction. And there are issues like maintenance, especially for patients who also have, let's say, concomitant myeloma, may have 20, 30, 40% of plasma cells in their bone marrow. And finally, at some point, we have patients who need to be retreated. Unfortunately, we do not have good criteria to decide which patients relapse and which are refractory. I can say that refractory are those who do not achieve what we want for them in the first line, but for relapse, this is much more complicated, and the definition is a moving target. There are many regimens that we have used to treat patients with relapsed AL amyloidosis. You can see some here that we don't really use, like carfilzomib-based regimens or lenalidomide-based regimens, or ixazomib-based regimens. These are suggestions that have been made by the ISA guidelines, and I think there are two things here. One is whether the patient has the 11 or 14 or no, so it's venetoclax, or if the patient has been refractory to daratumumab. Now, for patients who are naive to daratumumab, there are some options, and they don't have T1114, I would say. So either daratumumab with pomalidomide and dexamethasone or isatuximab with pomalidomide and dexamethasone. These are two studies that presented by Paolo Milani and Myriam Roussel in ISA a month ago. We have to remember that the outcome of patients who failed daratumumab therapy are not so good, and already Arnaud commented in this slide. What I think is important is that patients who fail daratumumab, usually they do not do as well when they are retreated with daratumumab-based regimens, and perhaps venetoclax and transplantation may be good options for these patients. And what about ADBCMA targeting therapies? This is a phase 2 study with belantamab mafodotin as a monotherapy every 6 weeks in very heavily treated patients, median 3 prior lines. About 75% of the patients, they had failed prior daratumumab. So the response rates are good, around 55 to 60%. The problem here is ocular toxicity. And you know that belantamab was stopped being available in Europe and US after a failed trial, but now we have 2 prospective randomized trials that show that if you combine belantamab with either bortezomib or with pomalidomide, things are totally different. So this drug comes back. So we will see how we can incorporate this drug in our treatments for patients with AL amyloidosis. And what about bispecifics? We are very optimistic that bispecifics are very effective, but so far we have small retrospective studies in very selected patients. Many of these patients had myeloma. Many of these patients did not have the characteristics of the typical amyloidosis patients. The responses are very rapid, very deep, but our experience in myeloma says that, bispecifics is not such an easy drug, and one has to be very careful with the use of this drug, especially for the long-term complications like immunosuppression and infections. And what about CAR T cells? So this is a study from Israel. It was updated in ISA with 13 patients now, and you can see that the response rates are very high. These are heavily pretreated patients, again, somewhat selected, and the response rates with this academic CAR T were very high. However, there were still deaths associated with the underlying amyloidosis, although the patients were in remission. And the final slide is a case of a commercially available CAR T cell, that's cilta-cel from Memorial Sloan Kettering, and you can see how effective can it be in a single, I guess, very carefully selected patient to receive this drug. So with immunotherapy, I think we have a lot of new options, but we have to be very careful and identify those patients that have the higher probability to benefit. And with that, I would like to thank you very much for the invitation and this very nice symposium. Thank you very much.
Thank you very much for the very interesting contribution this morning. It is amazing as you see what all kind of developments has gone up to now and what still is ongoing. I think it's very hopeful for all the patients here to see the difference between years ago and what is possible now. And then a lot of new developments are coming, so it's fantastic. Very amazing, so thanks for that. There is some time for questions. Probably someone has to ask something. Okay.
So thanks for the excellent talk, as usual. So I have one question. If you have a patient not in VGPR after the first cycle of DARA-VCD, and then there is no translocation 11-14, so I understand that if it's possible, you would like to go to stem cell transplantation and high-dose melphalan. But if it's not possible, what's the option? You will give VRD or bispecific in second line? For us, it's not possible. Belantamab is no more available, or you will continue and hope that...
Yeah, that's an excellent question. And unfortunately, this is something that we still see. As Arnaud said, one thing to consider is the stage and the situation of the patient. So if the patient is, let's say, stage 3A or 3B, then what I would do is try to add pomalidomide instead of lenalidomide, and be very, very, very cautious and follow the patient very, very closely. Of course, the alternative option, if the patient is close to VGPR, is to continue with the same therapy, because not all the PRs are the same. So I think one has to consider this on a case-by-case basis, but especially in high-risk patients, you don't have time to wait. Paolo showed very good results with the addition of pomalidomide to daratumumab, very high rates of responses, and it's better tolerated than lenalidomide, especially in lower doses. Of course, if the patient has T1114, Arnaud already showed that, okay, you add venetoclax, or you only give venetoclax. That's something we have to see which one is the best strategy.
What will be the best protocol with using belantamab, with which association, with schedules?
Belantamab. Yeah, I think the data that we have now from amyloidosis, but also from myeloma, because we have a very extensive program in our center with belantamab, is to give belantamab every 8 to 12 weeks. So the initial approval of belantamab was every 3 weeks, but the toxicity is significant, the ocular toxicity. So what we have seen is that if you give the drug every 8 to 12 weeks, it's okay. It's much, much better tolerated, of course, in combination with something. So both bortezomib and pomalidomide seem to work very well with belantamab. And we are in discussions to test belantamab in combination with VCD at first line, since the combination with VD was better than Dara-VD. So we'll see. So 8 to 12 weeks.
Another question?
No?
No? You had a clear story.
Yeah. Thank you very much.
Thank you very much.